go.
Hey, this is Dr. Sean Tierney talking about wrist issues. Wrist issues, and we're using musculoskeletal ultrasound to solve your problem, both with a diagnostic exam, with a further understanding, maybe guiding your rehab, and also directing you, hey, do you need to have surgery, or can we do a regenerative procedure? If that's the case, we can guide a needle using ultrasound to your exact spot. Obviously, for me, I'm working with another doctor to do that. So this musculoskeletal ultrasound is very useful at diagnosing the wrist in a way that you can't diagnose with an MRI or X-ray, because we can see mobility, we can see when things come apart, we can have you squeeze, move different directions and see what's open or closed. A lot of times with an MRI or with ultrasound, when we look at something, it looks like it's together until we move the wrist and see that it comes apart, whether that's a TFCC or a tendon or your scapholunate ligament, or even sometimes a scaphoid fracture. When we move, we can see that open up if something's unstable or not stable. It's a nice way to see anatomy, because with MRI and CT, also beneficial for the hand, then we can see a slice of anatomy, whereas with ultrasound we can look at any slice we want, and we can look directly at one tendon, whereas an MRI might show an oblique view, and it take a lot of reformatting to look directly at something. So we have this ability to see things clearly, and we can also recognize the nerves. We have microscopic probes where we can see the tiny little nerves in your hand, and we can look at the nerves and see where they're impinged, and we start to find that a lot of the hand pain is created by the nerves and not just a tendon, and we can start to address those nerves by hydrodissecting. And hydrodissection is a way to inject fluid to push the tissue off the nerve, so the nerve is freer, it gets better circulation, and feels better. So that hydrodissection is useful. We can also look at a structure and say, I think that the pain is coming from the scapholunate ligament. We're going to put a little bit of lidocaine or ropivacaine, a very micro dose, into that tissue, and we can say, hey, do you feel better or not? And we can decide if we were right or wrong. So we have this constant feedback. Was it the nerve that was causing the pain? We're right or wrong. Was it the structure, the ligament that was causing the pain? Right or wrong. Tendon? Right or wrong. So we have this immediate feedback. And what happens after decades of doing this, we start to recognize, oh, this is the common problem. This is what we're going to probably look at first. And we kind of go through things in a very earnest and complete way, where we're likely to see a problem that maybe was missed or was not able to be solved by a lot of other physicians, practitioners, clinicians. So we have the ability to see things. And one of the things we'll commonly see and commonly treat is like a trigger finger. So we see trigger fingers where the tendon is slightly irritated, slightly injured, and it doesn't fit underneath this pulley. We can do something to decrease the inflammation around that, to increase the health of the tendon, just by injecting right around that tendon or right around the pulley. A common thing we see with the wrist, probably one of the more common things we see in this part of the hand is the CMC, the base of the thumb, can be arthritic, and that can irritate the deep branch of the ulnar nerve, as well as the recurrent branch of the median nerve, and on the other side, the superficial branch of the radial nerve. So we can address the joint and the nerves around it, so we have a complete resolution of all the problems that happen. We'll also see instability in the wrist. The scapholunate joint would be a common joint. We can address that. We can direct something into the ligaments that are not healing, to help them heal in a way that they wouldn't heal on their own. Or we can sometimes, if we need to, we can refer you to surgery to stabilize that structure, and we can identify how unstable it is, and also we can identify how successful the surgery was. We can look at these nerves around the wrist. So we think this side is more radial nerve, superficial and deep radial nerve coming through here. Median nerve coming through this part of the hand, not in the little finger, half of the ring finger. So we can address the median nerve in the carpal tunnel, which is a really common problem. Everybody has heard of that. Median nerve in the pronator tunnel we address as well. So we can measure the size of the nerve. We can see if the nerve is tender when we push on it with sonal palpation, because we can look at the nerve and push on it at the same time. We can then hydrodissect the nerve and see if the pain is relieved. So we have these different ways to diagnose it. One is, does the nerve look enlarged? Does it look swollen? Does it look pathologically abnormal? Is it impinged? Is it tender to the touch? Another thing we can do is we can move. We have you move the wrist, and in certain positions, the nerve is likely to get pinched between tendons. And the nerve ideally would move out of the way of tendons, but if we do this motion and turn the wrist over, and the nerve gets stuck between tendons, we know we need to break the adhesion so the nerve is freer to move away. The ulnar nerve can be impinged underneath the hamate, very rarely at the Guyon's tunnel here, but more commonly as it splits off of the dorsal and branches splitting off of the main branch before the wrist. So we can look at these nerves, we can look at the structures, whether it's your TFCC, where you have your meniscus homolog, where you have your articular disc, you have your ligaments. We can look at the joints of the wrist, the joints of the hand, and address those with whether it's the ligaments on the outside that are making things unstable. We can see how unstable things are. We can measure those things, and we can direct an injection to prove where the pain is coming from and also to stimulate growth and healing. Once we know what the problem is and we've stimulated growth or healing or decompressed the nerve, we can use some tape to structurally stabilize that, or bracing to structurally stabilize that part of the hand, or even sometimes just teach you how to move better and not stress that as it's healing. And what I want everybody to know is if we decompress a nerve, you may feel better within a week or two. But if you have a structural injury, you have to think that's going to take about 10 to 12 weeks to heal. So your expectation has to be appropriate for your problem. If you're trying to get something to heal that's ligament, tendon, bone, you're looking at, probably 10 to 12 weeks. You're getting something to feel better. If it's to heal, it's where it's a compressed nerve, you may feel better in a few days. You may feel better in a few weeks. So different expectations for different problems is essential. So we don't want you to go home and say, how come I don't feel better? It was a month ago that I got treated, I should be better by now. And the answer a lot of times is no, it's not until 10 weeks that you start to feel better. Let's have our expectations appropriate. If you do feel better sooner than 10 weeks, it's probably because we decompressed the nerves, we helped the nerves be healthier, or we taped and supported your injury so it wasn't being stressed, or we gave you the right brace or the right exercises. So those things can make you feel better faster. Structural healing is going to take some time. That's just a brief overview of the wrist. There's a lot more complicated things to go through, but I think that's explaining why we can see things with ultrasound that you can't see with other imaging, why we can diagnose things a little more clearly, and I think you're going to be free to get rid of your issues.